So today I'll try to cover this difficult topic on optimizing the fluid management. I have nothing to disclose. So as we all know that management of acute pancreatitis, especially the necrotizing pancreatitis, has undergone a paradigm shift in last 1 decade. But that has happened predominantly after 3 to 4th week of illness. The initial first 1 or 2 weeks of illness, which finally determine the long-term outcome, still remains the same. It remains the normal fluid management, pain management, whether to give antibiotics or not, and nutrition. Out of which the fluid management has a little bit more potential in finally changing the actual natural history of the disease itself. So why fluid management is important? Because as we all know, pathophysiologically as well, the acute pancreatitis in early phase is associated with the severe level of cytokine storm, which is associated with increased vascular permeability, more amount of fluid sequestration. Along with that, there is a recurrent vomiting, poor nutrition, insensible loss, and all these things finally lead to hypovolumic and more of a redistributive shock, and which finally leads to various kind of local complication in terms of pancreatic necrosis as well as systemic complications. So the studies have, even in a human, it is not just a hypothesis, even in the human, Dr. David Whitcomb's group has shown that early pancreatitis, especially in patients with a multi-organ failure, are more associated with the capillary leak, which is associated with the decrease in the albumin as well as the non-albumin plasma proteins. In patients who are having a multi-organ failure, they have a more drastic reduction in the albumin as well as a non-albumin plasma protein, and that is why there is a loss of the oncotic pressure, which finally leads to a decrease in the intravascular volume, and it leads to a hypovolumic as well as the redistributive shock. So that is definite that acute pancreatitis in early phase is associated with a hypovolume and a redistributive shock. Whether reversal can improve the mortality or it can improve the natural course of the disease. So yes, the earlier animal studies have even shown that in patients who have the mice model who underwent experimental hemorrhagic pancreatitis, in that out of all the different kind of therapeutic options, only hydration has a little bit more chances of improving the long-term outcome or the survival rate as compared to oxygenation, peritoneal lavage, or any other inhibitor. Similarly, when we are giving the hydration, the chances of normalizing pancreatic blood flow increases up to 80% as compared to not giving a fluid or a low fluid volume. So these were the hypotheses why we chased the fluid therapy as one of the disease modifying agent. Even in the humans, as early as in 1980s, we have shown that the patients who have a persistent fluid sequestration for more than 48 hours, the chances of mortality is as high as 40 to 60%. Even in the latest study, Dr. D. Maredes group have shown that the patients with the necrotizing pancreatitis, with the local complications, with the persistent organ failure, they have a high level of fluid sequestration as high as 6 to 7 liters, depending on the type of the necrosis, as well as depending on the whether patient is having a single or the multiple organ failure. So because of this fluid sequestration, if at admission in the early phase, if you find a high hematocrit more than 44, increasing BUN or increasing blood urea over a span of 24 hours, it is more chances that the patient will finally develop a severe pancreatitis, multiple organ failure, and have a long-term morbidity. So, but the problem is that in acute pancreatitis, we have not yet developed a window period. So in acute coronary syndrome, in acute stroke, there is a door to balloon time, there is a door to needle time, but however, because they are having acute implications, in acute pancreatitis, even if there is a mortality, usually it gets delayed after 2 to 4 weeks. And plus the therapy is so simple, just by giving normal saline or ringal lactate. That is the reason I think we have not yet developed the importance of a window period. But if we are able to intervene early within 4 to 6 hours or within 12 hours, the chances is that the chances of a necrosis, chances of a SIDS, organ failure, all these things will get decreased as compared to acting later. So as of now, we still not have a concept of a window period, but I think in acute pancreatitis, if we develop that concept of window period, we might actually improve the outcome in a long run in early phase, which is the only therapy which has a little bit of potential of a disease modifying in a long run. So is this just a hypothesis, or do we have evidence? So even in the earlier animal studies have shown that the early goal-directed therapy can improve the survival in the animal models. What is in the humans? So there are various studies. So if in a retrospective manner, if you have given more than 33% of the fluid over a span of whatsoever you have given in 72 hours. If more than 33% has been given within 24 hours, then the mortality can be reduced. Similar studies have been even shown that the chances of a SIDS, chances of a length of ICU, length of stay, as well as the ICU stay can also be reduced with the early fluid resuscitation. Similarly, the studies have shown, the retrospective study over a long-term duration have also shown that early resuscitation is associated with the decreased amount of necrosis as well as the mortality. So what the guidelines suggest that the early resuscitation is important. There is no doubt about it. How we define early? Within usually 4 to 6 hours of disease onset, or at least within 6 hours of presentation to the hospital. How much should we should give? It depends on the baseline volume status of the patient. If patient is hypovolumic, try to give bolus, usually 10 to 15 ml per kg, and then reassess after 3 to 4 hours. If patient is improving, then you can go ahead with the maintenance therapy that we will discuss subsequently. If patient is not improving, you can consider for giving a repeat bolus. So one thing is for sure, that the fluid therapy is important, early therapy is important. How much we should give in a maintenance, whether we should go aggressive or we should go conservative. So aggressive has a little bit more useful because it can compensate the third space loss. It can manage the perfusion of not only pancreatic parenchyma but also of the cardiovascular, all the end organ damage. It can prevent the renal perfusion, everything. But at the same time, because by the time patient has presented, patient has already underwent pancreatic necrosis. So whether it can reverse the pancreatic necrosis, we are not sure. But and at the same time, if patient is already developed SIDS, capillary permeability syndrome, then it can lead to more third space loss, more amount of abdominal compartment syndrome, as well as the acute lung injury. And because of all these things, there is so much amount of heterogeneity in the data, in the different kind of terminology, whether it is aggressive, moderately aggressive, goal-directed therapy, or a conservative therapy. There is so much amount of heterogeneity within the data as well. So by and large, what we suggest is that after early bolus, what should be the maintenance therapy? So in mild acute pancreatitis, here this RCT was published a few years back, which was only on a mild acute pancreatitis, and in which they give aggressive maintenance therapy in form of 3 ml per kg per hour. In that, what they found that the clinical improvement at 36 hours was more, persistent SIDS and hemoconcentration was lesser in an aggressive group as compared to the conservative group. However, the catch is here is only patient were included only mild. But what happened over the time that the intensivist, because the early severe pancreatitis are mainly admitted within the ICU care. So what intensivist found that not just in acute pancreatitis but in all sepsis patient, if we are going ahead with the fluid liberal therapy, the chances of a ventilator days, the chances of CVS failure, CNS failure is little bit higher. Similarly, even in the patients with the acute lung injury, now what we are moving towards is the fluid restrictive therapy as compared to fluid liberal therapy. So as a gastroenterologist, what we thought that it can implement it to the gastroenterology in the acute pancreatitis as well, at least in the initial phase. So even in early in 2010, the China group has showed that if we are targeting a rapid hemodilution, means hematocrit targeting less than 35, the chances of mortality can be higher. Similarly, in the DiMeridia group have also shown that if the fluid resuscitation is more than, total fluid volume is more than 4.1 liter in initial 24 hours, the chances of persistent organ failure, acute collection, respiratory renal insufficiency can be higher as compared to more liberal therapy in terms of 3.1 to 3 to 4 liters of therapy within 24 hours. So based on the landmark waterfall trial was conducted in NEGM, where almost 249 patients were randomized in aggressive versus moderate fluid, where the aggressive was maintenance fluid was 3 ml per kg per hour for 48 hours, and moderate was 1.5 ml per kg per hour for 24 hours, and after that fluid was stopped if patient has already started orally. But what they found out was that the chances of a fluid overload as well as the cardiovascular failure, like in form of pulmonary rales or the peripheral edema, was much higher in a aggressive modeling group as compared to the in a moderate fluid resuscitation group. The same finding was also observed in the recent meta-analysis where the aggressive group was not associated with any benefit, rather the chances of a ventilator or the requirement of mechanical ventilation was higher. So based on this, now the recently published IAP guideline has also suggested that the moderate fluid resuscitation should be the target, 5 ml per kg per hour, and most important is the IAP and EGA both suggest that the goal-directed therapy where you are chasing the heart rate, mean arterial blood pressure, urine output monitoring, and the hematocrit or the blood urine nitrogen is more important. You should reassess the patient every 6 to 12 hours, at least 6 hours in initial first 24 to 48 hours, and followed by 12 hours. Yeah, and afterward is more useful. More above these clinical parameters, the invasive parameters like using a stroke volume variation, central venous pressure, CO2 monitor, or the CVP line, they can be also useful. However, we do not have any robust data whether they can change the outcome or not. So now we know that the what maintenance should be given. What kind of fluid should be given? Should we give colloid or crystalloid? So initially colloid was suggested to have a more chances of staying within the intravascular volume, so decrease requirement amount of fluid. But however, there are studies in the NEGM as well as the concurrent meta-analysis have shown that the colloids are associated with more chances of a renal injury as well as a mortality. So based on the EJ guideline also suggests against using any colloid. So now we are left with the crystalloid. So in crystalloid there are predominantly two solution, either normal saline or a lactated ringle or the ringle lactate. What we have seen that the normal saline is associated with little bit more amount of a hypercholeremic metabolic acidosis, acute kidney injury, and the immune dysfunction. Compared to that, the ringles lactate have a more anti-inflammatory profile. Even the studies have shown that the chances of interleukin 1 beta expression in the TNF alpha expression can be lower in a ringle lactate, but not in the ringers without lactate. So lactate might be the reason for a immunomodulatory profile as compared to the normal saline. Similarly, the studies have shown that it also suppresses, changes the innate immunity, and that can be one of the reasons for having a beneficial effect in acute pancreatitis as compared to the normal saline. So studies have shown that when there is a randomized trial, the lactated ringle solution is associated with the lower chances of a SIDS as well as a decrease in the CRP as compared to the normal saline. There is a recent published study in the gastroenterology which has shown that the ringles lactate is associated with a decreased ICU stay, decreased risk of hypercholeremic metabolic acidosis as well as the length of hospitalization as compared to the normal saline. And the meta-analysis have also shown that the chances of a SIDS can be reduced with the RL solution as compared to the normal saline. And now the IAP have suggested a strong recommendation that the ringle lactate should be the first line solution in acute pancreatitis as compared to the normal saline. There is again a Waterland trial which has been already been completed, and they are publishing the result in UEG week this year. So I hope we will have even better results in this debate whether to use a normal saline or a ringles lactate. Now what happens after 24 hours? So usually these patients cytokine storm and everything gets settled, everything is useful, and the initial fluid resuscitation is there for initial 24 to 48 hours. So guidelines also suggest that you need to give as need basis after 48 hours, especially if patient has already started the enteral feed, which is very important as already covered by my previous speaker. So even the studies have shown that if we are giving aggressive fluid resuscitation after 24 hours, that might not be that much effective and it will not change the course of illness. So again, the same aspect, that early diagnosis and a time window or the critical hour are most important if you want to change the natural history of the acute pancreatitis. So now the machine learning have also entered. That it is a recent publication where they have shown that there is an app, that is an ADAPT app, which is available. It can predict the requirement of a fluid in next 24 hours by a patient. If there is a lower amount of, if we are giving more fluid as compared to what the app has suggested, that the chances of a respiratory failure, ICU admission, longer hospitalization can be little bit higher as compared to goal-directed or a conservative therapy. But once again, the one size doesn't fit for all. So fluid management is not something like that we can give a random or a blanket statement that this 1.5 or 3 ml per hour should be given to all. It needs to be individualized therapy. because let's say some patient have a comorbidity in terms of a heart failure, kidney injury, lung injury, in that they might not be able to accommodate a higher fluid volume. In that, a more robust individualized therapy can give a better outcome as compared to aggressive therapy, which might be more useful in a mild pancreatitis. So there is a something called Rose criteria, where first is a resuscitation. When patient lands to your hospital, depending upon the hemodynamic status, you have to resuscitate with the bolus. After that, there is a optimization, that is a maintenance fluid, usually 1.5 to 2 ml per kg per hour, and followed by there is a optimization, then there is a maintenance, and finally you have to stabilization, ROSE, stabilization in by checking the goals by in form of either heart rate, invasive methods, urine output or lactate or the urine output, and finally you have to check about the evacuation or the evaluation, and you have to give the more fluid only if patient requires. So to conclude, fluid therapy is one of the most important, the cornerstone in the management of early acute pancreatitis. It has a potential to become a disease-modifying agent. Goal-directed moderate fluid resuscitation gives you a more optimum outcome. Ringer's lactate is now more preferred as compared to normal saline, according to even the latest IAP guidelines. And individualized therapy is most important rather than a blanket statement that 20 ml per kg or 3 ml per kg should be given to each and every patient. Thank you. And